So good morning, sir. Good Sunday morning, and thank you very much, all of you, including doctors, to make time for joining this seminar early in the morning on Sunday at 10 o'clock. In fact, MSSI has been conducting series of webinar since past whole month because of World MS Day, which was 30th May, about importance of early diagnosis. And most important thing is management and role of NGO like us. So that it is giving in a multiple perspective. So I'm sure it will be interesting, and because of presence of eminent doctors like Dr. Padma, Dr. Annu Aggarwal, Dr. Rajesh Iyer, and Dr. Dheeraj Khurana, we will be having a very interesting discussion on the latest therapies and all available. So, to start with, I would like to introduce our uh, society, Multiple Sclerosis Society of India. Our Multiple Sclerosis Society is the only NGO looking after welfare of multiple sclerosis patients. So, and most importantly, it is started way back 1985. So almost we have completed 40 years. So it's a big thing for any NGO to complete 40 years uh, in current circumstances, and we have been dedicatedly looking after welfare of multiple sclerosis patients. We are also affiliated with MSIF, that is Multiple Sclerosis International Federation, which is an umbrella body of all multiple sclerosis society across world. So we have been global right from the day one. So we are, so as far as the multiple sclerosis society's role is concerned, we are looking at the multi-pronged role. Now, first of all, as I mentioned, we have been disseminating all the information whichever is available about multiple sclerosis and its latest treatment. Another one is we are looking after rehabilitation of persons, rehabilitation of MSPs who are youngsters. So we are looking at starting from the counseling. Uh, then physical rehabilitation is physiotherapy, occupational therapy, speech therapy. We are always trying to provide all these facilities. And also, we have been providing financial aid to the whoever is possible for treatment, because the treatments are very expensive. But we are not uh, regularly able to provide for everybody's financial aid, but we have been giving wherever it is possible. Another major area where we are looking out is advocacy. That is advocacy about advocacy to government about the latest policies which are going to be beneficial for the patients. So now we will start our medical panel. And over to you, Pratibha. Pratibha is there. You are taking, right?
Yeah. Thanks, Mr. Sandeep. Though I'm not a doctor, I'm happy that you called me a doctor. So let's start with the moderation. Good morning, everyone. Welcome to today's panel discussion on importance of early diagnosis, initiation of treatment and management thereafter, role of support group. This panel is supported by Multiple Sclerosis Society of India and hosted by ET Health World. And I'm Pratibha Raju from ET Health World, and I'll be moderating this session for you. So today we have come together all about multiple sclerosis. So let's, without further ado, get on to the discussion. So let's begin by understanding the gaps in multiple sclerosis and how to address it, and also the importance of early diagnosis and early initiation of accurate treatment. This is very important because it all starts with that. And I would like to invite Dr. M.B. Padma Srivastava, Chairperson, Neurology, Paris Hospital, Gurugram. Thanks a lot, Doctor, for joining in, and your thoughts, please. Over to you.
Thank you, Pratibha, and thank you, MSSI. When you're looking at gaps, and you had this, I was listening to when this society was first established in the early 80s. We had a World MS Atlas, which sort of defined what's the burden of MS in India, and it was very, very low, which fell into the very low prevalence and incidence of probably even less than 0.3%, 0.3 per 100,000 population. That was really low. And now we know that the estimated figures, according to what epidemiology has given us, is more than 20 per 100,000 population, and even more. There are pockets where it could be much, much higher, and you multiply by the percentage of population we have, Pratibha, and so the stats are pretty humongous. And in the ongoing MS registry, which is, I think, you would be addressing that question much later, we already have thousands who are registered across the country. So that being said, it is this concept that MS doesn't exist in India was the first gap which had to be addressed. So people didn't look out for that. And then you do have a gap of wherein it starts with the person who's afflicted with the disease, because the disease spectrum itself is extremely varied. It's heterogeneous. So some where the attacks are in your face and big, and some where the attacks or the occurrence or the onset of disease is so benign and mild, you tend to ignore. So the awareness that MS exists and the awareness that this is the way MS behaves or can present is also not universally known. That's where I think the societies can come in a big way. The third thing is that it is very peculiar in the sense that it hits young people. And it sets apart from other diseases which can span across the different age groups. This is happening in young people who are at the brink of their career launch, choosing partners, or getting into the pregnancy, the childbirth. It is a young population who are getting it is the early the late part of their second decade, the early 20s and the 30s and the 40s. So that's an extremely productive life. And out of the blue, when it happens, you have this tendency to denial. I don't have this. Okay. And so you have, that is another big problem that we still have to address. It hits hard, but thanks to Google, they do go into it, and then they go into a tangent of either denial or trying to find something else. So although we have in our basket, in the armamentarium of really good strategies to address it, but the dictum remains across all diseases in medicine. You need to get early, start treatment early, the right drug to the right person in the right time. That's the adage which is across all diseases, and more pertinent. I think it is more pertinent when you're talking of a young person who's got this, affliction, because we have so much in the basket now. But when things come late to you, then the disability is already coming, then it's going to be an issue. So the gaps part of it, Pratibha, when you're spanning across the diagnosis, the awareness, and even amongst the clinicians, now for Mr. Arun, even the doctor missed it. So you need this awareness across all different specialties in the medical specialties. And also drive home this point that, look, this disease, if diagnosed early and you treat it early with the right drug, you make a difference of a whole new life for that person who's living with MS. You miss the bus, then you face the consequences. And that responsibility is again across everything. And there is a life after MS. That is where the disability part of it comes in. So at every stage, Pratibha, there is a gap. And in fact, I won't say that gap. They are probably, they're craters. They need to be filled in. There is a due process, certain process. And I'm sure there is a lot of research which is already being done, but a lot more. And I don't think the last mile has reached yet. We have miles to go before you hit that.
Thanks a lot, Dr. Padma. You set the tone well. Yeah, there is a lot of gaps. Everybody knows gaps or craters. So as Dr. Padma shared with us about the gaps and the importance of diagnosis, now I would like to go to Dr. Rajesh Iyer. Reasons for the delay in diagnosis, and are new drugs or treatment freely available in India? Over to Dr. Rajesh Iyer, Consultant Neurology and Epileptology, Manipal Hospitals. Dr. Iyer.
Yeah, thanks, Pratibha. Good morning to all of you. I think Padma Madam has summarized the gaps brilliantly, and that generally summarizes what's happening in India. Now, the problems are not only in the delay in diagnosis, as Madam was mentioning, the choice of medicines. And the disease as it begins with inflammation and progression. Both happen together. And many people think that, okay, I'm okay, and they don't come for treatment. They delay the treatment or wait for some more time for relapse. Even neurologists sometimes say that, okay, your disease has just started, why don't you wait? But unfortunately, these are the instances where somebody tends to get into trouble. Untreated, roughly half the patients will get into disabilities in about 15 years. And even when treated, if we choose a wrong medicine, for example, if somebody has a spinal cord or a brainstem lesion, and if we say, okay, your lesion load is not very much, it has begun, if we choose a wrong medicine, these are the instances where people, get into disability down the line. So it's important to choose the appropriate medication at the right time. And once treatment is begun, what I've seen is, there's complacency. That if you're on a particular treatment which requires an infusion once in 6 months, or you need to be on regular medications, often it happens that since after your initial treatment you don't have too many symptoms, then you delay the treatment or you ignore it. I've seen patients come back after 3 or 4 years with problems after the initial 2-3 years going well. Now, the problem with MS is in the first few years of disease, when there's maximum inflammation happening, your brain also tends to remyelinate. So your symptoms tend to improve pretty better. So in that instances, the disability is not much. Then this is particularly true in younger patients. And younger patients also tend to have more aggressive disease. So it's important that patients are educated about the necessity of being on regular treatment and classify patients into the risk of disabilities that they can get into. So some patients have a very benign MS. There, even if you are a little lax on the treatment, you're still fine. But if you know that the prognostic factors are bad, for example, males, age above 40, involvement of descending tracts, bladder involvement, cognitive changes, spinal cord, brainstem involvement, all these things indicate, or large lesions, and poor response to initial line of treatment. These are the instances where somebody has a high risk of disability. And secondly, if the response to initial steroids is not great, then you need to hit hard. See, sometimes what happens is the disabilities which persist after initial treatment, they don't get better. And we would have lost time in the healing process, and the deficits tend to persist. So after a relapse or an initial attack, one should go all out to restore the neurological functions to the maximum possible so that we can maintain at that level. So these are some of the thoughts I have at this point of time.
Yeah, thank you, Dr. Rajesh, for those valuable insights. Now I would like to get on to how many percentage of patients are having disabled life with MS in India, and also why rare disease status should be given to multiple sclerosis. So I would like to go to Dr. Annu Aggarwal, consultant neurology, specialist cognitive and behavioral neurology. Over to you, Dr. Annu.
Thanks, Pratibha. And when we come to how common is MS, Dr. Padma has touched on it. Say, in the beginning, in the last 20-30 years ago, it was believed that the incidence is 0.3%, 0.3 people per 1 lakh population are affected. And MS was at that point considered a disease of the Western world, but that we know is not really true. And at the moment, WHO estimates that there are over 30 per lakh people living with MS in India itself. And probably this itself may be an underestimate of the actual figures. So if we extrapolate it with the Indian population, we have at least 5 lakh people currently living with MS, and the figures again may be higher than this. So which is a big number. We are looking at people who are at a young age in early adulthood, at the peak, at the beginning or peak of their careers, and they're just starting life. So, which is a burden not only to the families but also the social structure of the country. And if we can, and we have at the moment great treatment available for MS. So if we do diagnose the disease early and offer prompt therapy, we can prevent disability in these patients, which does, as we heard, accumulate over time. Yeah. So WHO defines rare diseases. It's arbitrarily as any disease where the prevalence of the disease is less or less than 60 per lakh population of the region. And by that definition, we are looking at multiple sclerosis. If we look at India, the incidence is estimated to be 30 per lakh. So it does qualify as a rare disease. And now, why MSSI and we doctors are advocating for this to be included as a rare disease is that, unlike, say, diabetes or cancer or stroke, which we all are aware of as doctors, even if though we may not be specialists in that area, we know it. The lay public knows about them. They know if they have particular symptoms, they need to meet a doctor, and they have a rough idea of what the disease is about. So at a patient level, at a family level, and at a medical level, people are aware of it. So diagnosis is usually not that delayed as is the case with rare disease. And we heard Mohan talk about it, how he's educated, working at a highly functioning job with access to the best doctors in the country. His diagnosis was delayed just because it's a rare disease. So diagnosis, the awareness helps in the patient seeking help, and it also helps the medical system providing the correct investigations to diagnose the disease. Then it also helps in providing medications. For instance, we already have a policy in the country which is called as the orphan drug policy, where for rare diseases, the government and the government agencies, with help from NGOs and pharmaceutical companies, provide access to drugs across the country, and at times with subsidized rates, so that patients with these rare diseases are benefited. So if multiple sclerosis is included as a part of the rare disease, luckily most of the drugs which are available for treatment of multiple sclerosis in the Western world are now marketed in India. So we would then have inclusion of these facilities as a orphan drug policy, and that would help the patients immensely, and the outreach of treatment to the patients would vastly increase. And
thanks a lot, Dr. Annu, for your
Thank you,
well-rounded,
Doctor. In fact, I would like to
answer for the
just say a
questions.
word that
Yeah.
Multiple Sclerosis Society, MSSI, is also representing for classifying multiple sclerosis as a rare disease. So, of course, it is work in progress, and with support from all of these people, we will be able to get it shortly. Let us hope so. Thank you.
So as we've got the perspective of doctors here, now I would like to get on to Mr. Sandeep only to the conversation. So I would like to ask about the challenges faced by patients due to the lack of awareness about the condition, which I think was hinted by the doctors here as well, and lack of trained healthcare professionals to diagnose and treat the disease. As you work from the ground, you meet patients, a lot of patients, so you'll have a better understanding of the same. So if you go on with your pointers there. Thank you.
Thank you. See, as far as the lack of awareness is concerned, unfortunately, it is really a serious problem as far as India is concerned, because apart from neurologists, even at GP level, people are not aware about it. So many of the doctors, suppose forget about complete Mufussil area, even suburbs of the cities, there also, if many of the GPs and all are not aware about multiple sclerosis, the whatever the symptoms are there, and these symptoms, initial symptoms, are completely ignored, and many times some wrong treatment is given because of some other disease. Again, Arun is again one of the leading examples in that case. So such type of thing can happen, and because of not getting early treatment, unfortunately, people have been suffering for disabilities. Earlier, the treatments were not available. See, 20 years back, DMTs, disease modifying therapies, were not available. Very few were available. But now, fortunately, lot of treatments are available, which can, if it is done at the right time, definitely can stop the disability or growing any further. So that is what is really important. That's all I want. So
Thank you for this pointers, Mr. Sandeep. So now I want to go back to Dr. Padma. Dr. Padma, can you tell us about the multidisciplinary management of MS and why is it crucial, and how is the treatment ecosystem shaping up? We know there are gaps, but we also are trying to, shaping up in the things which are available with the availability of innovative products. So if you can touch upon that, Dr. Padma, over to you.
Thank you, Pratibha. So one is, as I said, you have this big armamentarium and you have levels of treatment. We have level 1, 2, 3, and 4 as it exists now. The medications which are low potency for, say, a low disease burden with low side effect profile. And as the disease is advanced and you have severity increasing, you do have bigger drugs which are more potent. The flip side being they do have side effects to contend with. So somewhere you would have this a tightrope walk of balancing act of what is the disease severity and what kind of a medication I need. And so you have the high intensity therapies, and I think we'll be talking about it a little later. Said that though, it is not just drugs that a person with MS would need. The entire spectrum of a disability, part of it, starts with mental health, the coping up strategy. And I said this is a young person. There are a lot of challenges that the young person has as against an extremely small baby versus, you say, an elderly person. The challenges that a 22-year-old, the person has just finished graduation, has got an admission into a Ivy League, college, or has just got a dream job, and then is to travel and move across and live independently, or has found a life partner and there is a marriage date which is set, or is married and they're embarking on trying to get the first child. That is when this MS is hitting. And then the whole world changes. There are postponements, and then there is societal acceptance of this whole thing. So there are breakages at various levels. The person has to contend with the disease. They read the Google. The second thing is to contend with the life changes which come across. The mental health thing, something as devastating as COVID has witnessed, is happening to this individual. It's not a small thing. Said that, the disease itself as is causing disabilities and the cognitive issues which may not be in your face, and it is very seldom even looked at in a busy clinic. You always look at what is a disability in walking and balance and power and in stiffness and what have you. You're not even looking at, you don't even have time to look at the personality changes and the mental health issues, and the cognitive issues come in very early, and it has been established. That is one disability. And then you have the disability measurements, which could be, they're being, refined, and they're being defined well now. The composite MS outcomes, which take in different disabilities in your performance with a hand or a leg, or, and then there are disability status scoring systems. You need to get certified and so on. You are looking at all this. So then you have to look at their sexual health. You're looking at the continence, the urinary and the feces continence. They may be, in a bedridden state, there would be contractures, there would be bed sores, there are, skin changes. Then there are this whole thing about disability, as I said, life after having been hit with MS, which includes physiotherapy in courts, which is not just exercise regimes. It's a whole lot of things out there. Look at the number of specialities, Pratibha. I need a urologist, I need a psychiatrist, I need a psychologist, I need a probably, the different systems which in there, and a plastic surgeon. It expands. So it is not just a clinician or a neurology. So a multi-speciality, and then throw in this big system where it needs support, the societal support, and that's where the MSSI and all these societal groups which have come across as NGOs. So you have the entire thing, and then the economics. You can't ignore this elephant in the room, Pratibha. Health economics, can't ignore them. You need support there. So when in this whole thing, I must bring in the health policy makers and implementers and everybody. So it is a joint system. So, and I think that's the reason when we say medical, yes, it is still multi-pronged, multi-strategized, so multiple level are required, but it goes beyond that. So you need a multi-pronged strategy to address this problem at the very root and make a difference to a person who's got this problem.
Thanks a lot. It shows how much multidisciplinary system is needed for MS. Thought about string of pointers there from Dr. Batma. And we have Dr. Dheeraj Khurana, in charge of MS Clinic and Professor Department of Neurology, PGIMER, Chandigarh, India, joining us. Thanks a lot, Dr. Dheeraj, for joining in. So I would like to go to you and ask about the challenges first. If you can just give us, though we have spoken about it, we would want to hear from you also. Challenges faced by India due to lack of awareness about the condition and lack of trained healthcare professionals to diagnose and treat the disease. Yeah, if you can just go on with it, Dr. Dheeraj, over to you.
Thank you, Pratibha, and thank you, MSSI, for this excellent platform today. I think we've heard quite a few thoughts on the various challenges, and just to reiterate, these challenges are primarily related to a delay in diagnosis. And you know what? Usually these delays happen either because it depends upon the variety of symptoms that the patients come up with. The common symptoms being visual symptoms. You may have visual blurring, and they will land up with an ophthalmologist or even a general physician, and who may not really suspect multiple sclerosis. And what they land up doing is either no major treatment. And the reason why no major treatment is given in the beginning, a lot of these attacks are self-limiting. And that's what the hallmark of MS is versus the other associated illnesses like, say, for example, NMO or MOG. They are not as self-limiting and they are more debilitating. So MS may, in certain cases, may tend to be a little bit less debilitating in the first few attacks. So they may have milder attacks and they may get okay, and people ignore them. And that's another thing why it gets there's a delay in the diagnosis, because a lot of patients who have the first few attacks, they may get okay and they may just ignore it as a minor symptom. And we see this off and on, almost on a daily basis. We see that in our outpatient, and they don't seek help, one, and when only when a major attack strikes them, they come. Then I think one of the other challenges which earlier used to be there is not just lack of early diagnosis, lack of say the availability of the right tests. For example, an MRI, although now the MRI, especially in the big cities, are very easily available, and even, for minor complaints, in fact, that's got a downside to it. You may overdiagnose certain things. And thanks to the widespread availability now, we are even getting patients who do not have MS by symptoms, but who have MS by the MRI, what we call as radiologically isolated syndrome. And interestingly, that this phenomena of RIS, that is the imaging showing MS, but the patient not having symptoms, is now considered to be a precursor of MS, which has enough evidence, and we may even pick up these patients before anything happens in MS. And that's a great thing, actually, because what we were talking, why early treatment is needed in the challenges, that is the very reason. For any disease in the human body right now, we are reaching a stage, we're not reaching, we've already reached, where we talk of preclinical. That is when the patients or the people do not have the real manifestations, but even have the silent symptoms of those disease. We need to treat them, because once the disease starts, there is already so much of damage which has happened, which may not reverse. So we are looking at preclinical or pre-symptomatic stages of the disease, and it's the presence of MRIs and maybe sometimes over investigation we may diagnose. But overall, there has been, I think, these challenges have slowly, I think, been overcome now, and there is a huge amount of awareness amongst the ophthalmologists. Physicians may not be as much, but if the MS patient lands up with a neurologist, there is a little chance that MS is going to be missed. And there is a low threshold for, at least in the neuro the field of neurosciences to get a proper investigation and diagnose patients. Then these, as far as the diagnoses are concerned, these are the major challenges. And of course, I'm sure you'll be talking of the challenges for treatment, which maybe you can discuss later.
Okay. So now, as we have heard a lot about challenges, now we have this question on the MS registry, how important it is to have one, to have a repository. So I would like quickly ask Dr. Rajesh, so do we have any MS registry and how important it is to have one?
Well, so there is a registry. I'm not part of the registry. I think Dheeraj and Padma ma'am and Netra in Bangalore, Thomas, these are the people who are presently running the registry. So I have encouraged my patients to be part of the registry. I think one of them can answer this question in a better way.
Yes, Rajesh, you should be part of this registry. Dr. Rohit Bhatia is the principal coordinator, and it is his been brainchild to get this MS registry from the ICMR. And yes, most of us are part of it. And I must say, Rajesh, how are we missing you? You must be. You would be from tomorrow. Seriously, Dheeraj, you can explain more on this.
So
Okay, sure. Thank you.
Dr. Dheeraj, if you can give us some light on the registry part. Yeah.
Well, Dr. Padma's already given you the apt introduction. So yes, the registry is already up and about, and it's over an year now, which is running across many centers. I can't count them on my fingers right now, and the centers it includes both private and government hospitals, which are part. And Rohit initiated the registry with the funding, with the help of ICMR, and we've got a very, very, I would say, eye-opening information and eye-opening data on that we already have close to 5,000 patients on that, which is a huge number if we compare to even the registries in the West. Countries like Sweden, or even, which is one of the topmost countries having data on MS, they also would not have this rate of high number of patients, and that's primarily dependent on our huge population. One state of ours is probably got more population than the whole country in Europe, and that's actually a reflection. So we look forward to actually accumulating this data. And why you asked what's the importance? I think it's extremely important, first of all, to identify the clinical characteristics, but more than that, to really get identified with the burden that we are facing, which we've just been discussing. Everyone just said that MS was at one point of time not considered to be a disease of the Indian subcontinent. It was a disease of the West. But now we need to show the world that there is enough MS, and how focus has to shift. So there have been things which have happened in the last few years, which is actually focusing on LMICs, which I would maybe state a couple of them. All the development of all major medications, they took place in the West because of various reasons. You have the resources, you have the funding, but we had some low-cost medications like rituximab, which we all know is an excellent drug, and it's working very well. Very recently, with the WHO along with MSIF has given approval, and in fact included rituximab in the essential list of medications, which is a big step. And why they've done it is to increase the accessibility in countries like India and other LMICs. In fact, because till date, rituximab, which although I won't go through the entire story why it's off license, because it was not developed for MS, but the mechanism and its use in MS is excellent. It works very well in MS. And finally, now we have an endorsement from one of the big agencies like WHO, which says that it's good to use, and that's the reason, and it should be made available in all these countries, since it has ample of evidence and clinical trials also now, which almost give it like a level 1 evidence of efficacy in MS. So these are a few of the things why registries are important.
Dheeraj, I can actually quickly, Pratibha, I think registries are important. One, to get the actual highlight the local challenges as well, and also to understand the way the disease behaves and progresses in this set of the socio-economic ethnic population. So say, for example, you take pregnancy, then you look at the medications, how what is happening to these individuals who are diagnosed with pregnancy, what's happening to their pregnancy, how is the childbirth. So this registry would be separate. And also the registry as regards what has been the first line of drug which has been introduced into different states. What's been the average? How many of them have actually got missed? What is the timeline of from the onset of complaints to the first line of drug which has been initiated, called the treatment gap? So these are some of those things which are innumerable. Even there are radiological biomarkers which are getting in, the MRI markers. Are they different? Are they same? Is it the same as is being reported in the West? And it's mostly it is. And also some chemical biomarkers. That the list is endless, Pratibha. I think registry and close to 6,000 people right now into the registry will give huge amount of data, and this will span across now decades because the onset has been done and it is rolled out now. We need more people joining into this registry. That's important.
Yes.
True. Yeah. Thanks a lot. So I would like to go on. Thanks for sharing those valuable pointers. We know how important is the registry. Now, any patient with any disease would want to live a normal life. Dr. Annu, can you tell us about the patients with MS life? They want to live a normal life. How about the approach of early hit, hardened management of MS? If you can throw light on that, Dr. Annu.
That's very important question. So, as we've heard from Dr. Padma, Dr. Iyer, Dr. Khurana, and Mohan, that this is a disease which affects young people, at the prime of their life, where a new phase of their life is starting, new job, new family, children. So, we would want as doctors, as a society, to see that they can lead as normal a life as possible. And I think we should, as a family, a society, and as a medical fraternity and MSSI, aim to fulfill that dream. And I think if we can surmount the barriers of early diagnosis, we luckily now in 2024, we have drugs to help us achieve that. So the idea is to diagnose these people, provide the correct therapy, provide the multidisciplinary care, focus on a patient, see that they lead a life, and also to give them confidence that that life is possible. And I think in this respect, Google would be backfooted, because what has happened with MS and the way the treatment has evolved from, say, no treatment to interferons to very effective oral drugs, the quality of life of patients has drastically improved if we've been able to diagnose them in time. So if you go on Google, the data which is available about disability stories may not actually hold true in the current context. Having said that, this is an evolving field. We have heard that MS is a very heterogeneous disease, and one treatment doesn't fit all. So, while these treatments are being enforced, and the current approach is that you have a patient with MS, you see how many relapses they are getting in a year, or new symptoms, and you also do periodic MRIs and see that how many relapses they're getting, because sometimes patients do develop changes on the MRI without any symptoms, and given together, if you add the clinical relapses and the MRI relapses, say in 1 year, if that is high, you escalate therapy, and you go from step 1 to step 2 to step 3 to step 4. The idea being that the higher the therapies at a higher step are definitely more effective, but you have to be vigilant about their adverse effects, which may be more severe or more frequent. But overall, the risk-benefit ratio is in favor of the patient, and the patients would benefit from the therapy in controlling multiple sclerosis related inflammation and degeneration. But drug costs are prohibitive, and if we make concentrated efforts, they can be reduced if the patient base using the drug increases, and if we increase the outreach to the patient, that itself helps reduce the cost of the drugs. But I think we are looking at HIT therapy very closely.
Adding to it, thanks a lot, Dr. Annu, for those pointers. Adding to it, Dr. Dheeraj, you have anything more to cover on how about the approach of early hit, hardened management of MS?
Yes, going early is basically early intensive therapy, as we call it. I think I'm a very strong proponent of early intensive therapy. Reason being, for whatever the discussion preceding this, we've been talking of how important it was to diagnose early, and why it's important to diagnose early is because the disease is very severe, mostly severe in the first few years. Now we do have ample evidence and also ways to detect which disease or which MS is going to behave more aggressively, what we call as aggressive MS, or we call as highly active MS. So thankfully, over the years, data which has accumulated, we can find out, for example, a patient who's had more than 2 attacks in 1 year, or even more than 1 attack in 1 year. We consider that as a disease towards going towards aggressive, or who have symptoms relatable to the spinal cord more and who do not recover completely. These are some of the examples. So these are highly active disease, and even right after the first attack, we can predict that this disease is not going to behave in a mild fashion. And these are the cases we should be very, very, I would say, surely treat them with high early intensive therapy, or hit them hard with a therapy. And thankfully, we have all kinds of treatments available. So if cost is a constraint, I would not shy away from saying rituximab is one of the best therapies, and all my colleagues, I think they have been using a lot of rituximab across the country. In fact, to name quite a few centers across the country, in fact, because that is easily available, low cost, patients tolerate it well. Every 6 months you have a therapy. But if we really need to offer all the latest treatments, even those are available currently in our country, like Ocrevus, natalizumab, Dr. was talking, and those are excellent drugs. In fact, I usually give the believe in offering all these medications and then discussing it with the patient on a shared decision making pattern, so that they know what is available, and then they take a right decision based upon their own personal scenarios. And that is the reason, ideally. And there is ample registry based as well as trial based data which tells us that early intensive therapy is definitely better, because it reduces the chance of a patient going into long-term disability maybe 10 years down the line, versus an escalation paradigm which was actually practiced many years back, that you go with first line platform therapies, then you go on to a high end. We are currently seeing a paradigm shift, and more patients are actually identified as candidates to go for early intensive therapy. And why we should do that? Because we are not harming them. There are two things that we need to see in a treatment: high efficacy and safety. So if we have a treatment which is highly efficacious and safe, I see no harm in giving such therapies, versus there are conditions where you have therapies which are highly effective but also have serious side effects. There are drugs in rheumatology, in cancer. Cancer is also same. I'm not saying this is the same thing, but we hit hard, but you have a lot of side effects. Here we hit hard, but side effects are minimal and are manageable. So that's the balance that we create, and we should, I think, go ahead with that.
Thanks a lot, Dr. Dheeraj. Now, again, going back to Mr. Sandeep, we would like to learn the importance of early diagnosis from the doctor's perspective. We have already heard. So, from the collaborative perspective, if you can give us the importance of early diagnosis and early initiation of accurate treatment, and most importantly, challenges in getting reimbursement for treatment in India. That must be a challenge. So, patient advocacy perspective is needed here. Over to you, Mr. Sandeep.
Thank you. Thank you, Pratibha. As far as early diagnosis is concerned, definitely it is important to have early diagnosis. And as all of our doctor panelists have suggested, that early treatment is the absolute necessary. So now early treatment, all this early treatment definitely involves a lot of money. So that is where we would say advocacy comes into picture completely. Most important part of advocacy is insurance. See, if insurance is there, then it will be possible insurance which is covering properly. That is very crucial, because now insurance policy is specifically designed to cover 21 disabilities in which multiple sclerosis is also included. The 21 disabilities under RPWD Act. So all the insurance companies have designed the policy for this disability. However, there are major lacunas as the policy is not affordable for premium wise, and the issue is whether everything, the DMT, basically they are being administered like a chemotherapy drug in outpatient department, whether claims will be settled properly. So this is a gray area which we want to convert completely into uh, confirmed statement from insurance company that this will be covered. DMT's treatment will be covered as an outpatient treatment, just like chemotherapy. And it has to come up. So we are doing a lot of advocacy for that, and also getting insurance policies for people. Then another area is classifying multiple sclerosis as a rare disease. The moment it is classified as rare disease, as Dr. Annu Aggarwal also has specifically mentioned, that the moment it is classified as rare disease, we are getting benefit for research aid also and the treatment aid from the government. So that is where we are looking at support from the government, and we always look forward to it. Thank you.
Thanks a lot, Mr. Sandeep, for your thoughts. I know there are a lot of questions. We are running out of time. I think the MSSI has given an email ID. It's hoadmnmssi@gmail.com. So whoever has any questions, please write to them. They would be getting on to the expert doctors, and maybe they will get the responses which is needed. So
We will definitely do that.
yeah.
Promise,
So
Pratibha.
Thank you.
there are a lot of important questions on the drugs, on the scan. I think these needs to be addressed, and the doctors would definitely do it. So with that, we have come to an end of this enlightening session. Thanks a lot for the panelists from ET Health World side. Over to Mr. Sandeep. Thank you.
Thank you very much, Pratibha, for conducting it in such a lucid way. And also all the doctors, Dr. Padma, Dr. Annu, Dr. Dheeraj, and Dr. Rajesh, to be here on the busy, means rather sparing their Sunday, the Sunday morning for this event. And all of you participants, we are really happy. Please send your queries, because unfortunately today, due to paucity of time, we could not take the questions for this session. But we are very happy. We will be sharing this question to the panelists and get back to you. So please go ahead. Thank you very much.
Thank
Thank
you.
you.
Bye-bye.
All the best. Namaskar.
Okay.
Thank
Bye.
you.
Bye.
Bye.
Thank you so much.